like to thank, that's apparently this is the title of what I've been asked to discuss with you today. And when I asked to discuss that, I said to Dr. Iakovou, I don't want to do that. I don't want to present anything for different reasons. The other thing was that I always found it a bit very interesting, and instead of having lectures, to have discussions. And I think that's going to be the new format of the congresses. No lecture, just discussion. And I decided to do it this way. So instead of giving you slides, I will I'll ask questions, and I will listen to your answers, and possibly I will find them I'm sure I will find them very useful, because in the near future I will have to say something to the governmental authorities, and possibly I have to be there in the decision tables to see how things will go. And now we're talking about structural. Structural is a number of things. TAVI, mitral repair, mitral tricuspid replacement of tricuspid, VFO, ESD, and LAO, different things altogether. In Greece, what we've got as reimbursement is for TAVI and mitral repair, tier. Nothing else reimbursed. So the first question is, because we are going to be asked, do we have to push for, first of all, for a tricuspid repair? Are you persuaded that's useful and the government has to pay? Because then when you go to the NHS system, it's not somebody has to pay, it has to be the government, and somebody has to find the money, and somebody else, the money have to be found, something else has to be stopped, or be less money for something else. Do you agree? Who agrees that tricuspid repair has to be reimbursed by the NHS? Dr. Pilates? Everybody, yeah? Or the others, Dr. Mamarelis, do you agree? Do you think that the government has to pay for tricuspid repair? Are you persuaded by the tier for the tricuspid valve? Because what we know till now is that we don't know, we don't do it here in Greece.
It's tricuspid repair or replacement?
Repair, first of all.
Okay.
Tier. Because what we know, in Greece, we've got very limited experience on that. There are very few centers, very few cases. The majority of them, they are private hospitals that they do it. Officially, you can't get reimbursed, although now the committees pay lip services, and they agree to pay for some of TR in the tricuspid valve. But when it comes to, then it becomes generalized, then we have to do it for everyone who asks for it. What do you think?
I'm not persuaded that it's useful till now. Maybe next year.
So the data are missing.
Yes.
It's useful, but it says that the question is that in cardiology, always we think what is useful is something that gives life expectancy, prolongs life. But we have to, my feeling is that we have to rethink about treatments that they don't prolong life, but they give better quality of life to our patients. The oncologists, what they do, they don't prolong lives, they have better quality of life, or they give 6 months and they say we've done something very important. And how much we have to be so hardly regulated in cardiology and to be judged only by prolonging lives. I don't know, it's a very important thing that we have to discuss. What do you think, Jan?
These are, really difficult to answer.
What is the situation in Germany?
Last year we had Dr. Anastasakis from economics professor, specialized on health economics. So I know he was asked about, if you have a treatment of amyloidosis and you have something that costs more than 15,000 euros per month, a treatment of a patient with amyloidosis, which doesn't prolong life, and you compare that with a triclip procedure or maybe with a VOC replacement. So which one gets to be to get more benefit, especially if the patient is carefully selected and you have an optimized procedure. So I think it's a balance act, and of course it's a zero-sum game. So not everybody can. So Aki.
Is to take the question where what happens in Germany. I think we'll have definitely another constellation regarding health system. That's the first thing. But I think there are things I see it practically exactly the same way. We do in the cardiology act on a high interventional level, like palliative care, don't we? It is high interventional, high invasive, but it's actually palliative care and medicine. So maybe we should consider not only having reimbursement for quality of life, but to see the patient that is really in the ward with GOT and GPT sky high, GOT more than GPT due to the right heart problem. And imagine if he could have some more time at home after a treatment. And this could be the way to open the door and reimburse such procedures. And that's the one thing. And the other thing, which is part of the sessions tomorrow, actually, but I would just have to mention that. I mean, maybe we need to consider the time that we treat these right heart patients. We do it way too late. The annuli are bad. They are dilated. We cannot do much. Maybe in the future, when they are being treated a little earlier, then we also get out of quality of life improvement and get into maybe outcome change or even more. And the translational approach is also necessary. What happens to other organs? What happens with the liver when we treat the heart? And vice versa. So maybe we need another way of observing things, and we need to learn.
There are many issues that we don't know, and we saw this publications of CHIP, of this clonal MOPs of the determinant potential. So there are, you have these CHIP mutations, and we have patients with cancer, aortic stenosis, and in coronary artery disease in a tandem. So maybe there are certain mutations that can be identified, and maybe we have to be open-minded for that. And we don't know. We have to honestly say that we don't know how these things evolve, but we have to be open with the new challenges, and maybe as a president of a cardiological society, so you have to be, you have to push some people forward to be open to these new, let's say, avenues, because of course you need to clarify which procedure is more worthwhile, or which pharmacological procedure is more worthwhile. But at the end of the day, you have to make choices. And we were discussing before that someone who is 70 years old and has aortic stenosis doesn't have a normal life expectancy, no matter what he does. So he will live approximately 9 years. So it's not like 14 years, like the life expectancy for a patient with 70 years old, no matter what he does. Of course, if he doesn't do anything, he will not live 9 years. But so it's central, I think, for the cardiological community to say that clear. So we have European guidelines and need to be incorporated by Greece as well. So there is no need to wait for 5 years to have a recommendation from 75 to go, the recommendation to go for 75 years to 70 in order to have reimbursement for these procedures.
What do you do in Italy? Do you reimburse for TIA and tricuspid valve?
I don't understand.
In Italy, do you get reimbursement in the NHS hospitals for tricuspid repair?
It depends because it's for palliative care. Sometimes it depends public from private. It's the same for your experience, I think. But for tricuspid, the problem is the timing, the timing of the procedure. But it's the same. Sometimes we don't. Sometimes we perform a trick valve too, 3 cases for palliative care, and we have just a reimbursement for palliative care. It
So is
depends
that,
on.
So is it less reimbursed
We have
for palliative
difficulties too with the reimbursement in public, in a university too. We have difficulties.
So it's difficult in Italy as well.
It depends. Private, maybe no.
No, private is all right. Private, you pay your private insurance pay.
Yeah.
But if it's the NHS,
It depends on the region too. For example, in northern is better than in the center and in the south. It depends on the region. Different laws.
But here, private insurances doesn't pay TAVI procedures in private hospitals if they don't have approved by KC before. So I think the situation will be the same with TIR as well.
all right. Let's ask you something else now. One of the main things that we're going to face is that the law is that you need. The law says here in Greece that you need to have a cardiac surgeon on site in order to be a structural center. And there's a lot of pressure from smaller hospitals, especially NHS hospitals, because the private hospitals, they don't have that problem. Bigger or smaller or bigger, they have cardiac surgeons, is to perform TAVIs, especially without cardiac surgeons on site. That in practice means that we will have many small centers. Many small centers. Do you agree with this? Should we go towards that direction? Or should we say, we need to have something that will restrict the implementation of the treatment in bigger centers and not having many small centers all around the country.
Pro and cons, it depends on, in Italy we have the project TAVI at home, okay, without the cardiac surgeon, but the consequence is small center, so a dilatation of the network. So it depends, pro and cons. For example, for left atrial appendage, no cardiac surgeon.
That's fine, yeah, I know.
It's a problem of mindset, I think, because maybe, in my opinion, left atrial appendage closure is more important having a surgeon not
TAVI.
far. For TAVI, no.
The
we
reason
can
why,
discuss about this.
The reason why we say cardiac surgeons is to restrict the number of centers.
Yeah.
It's not for that we need the cardiac surgeons to do TAVIs. We need vascular surgeons. We don't need cardiac surgeons.
But from time to time, especially in the early learning curve of a small center, maybe you need. And
I've got a lot of doubt
from
on that,
time to time, yes, maybe. So we had out of the 2,300 cases that we have done in analysis, so we had approximately 8 or 7, maybe Elias knows, how many cases do we need to convert TAVI procedure to surgical procedure? Especially in the early days, it would happen, maybe NASUS. No?
Yeah, the early days was difficult because so was
But,
also the experience.
from time to time,
all the equipment that we had, all the valves were very cumbersome and were very difficult to be sort of. They had problems themselves. Yes. But nowadays, with all these new devices, the possibility of needing a surgeon, and if you need a surgeon, the possibility that the patient will survive is zero.
May I ask, Aki, what's the experience in Germany? Of course, we know that in Germany surgeons are inside
But again, I'm saying the reason why we say surgeons is not because we need the surgeons, is to say that we don't going to open the game.
Do you have an idea?
That's very simple.
Germany is the highest implanting country in Europe. Do you have the approximate number of TAVI cases that have being done per year, and how many centers do you have in Germany?
Well, I would like to avoid saying a number because I'm not going to be accurate enough. But the thing is that the heart surgery is a precondition, and this alone is a criterion that has the whole situation under control. So this is the first thing. The second is, I think that indeed is it statistically significant if we take all the stenotomy patients, that like an emergent stenotomy, and you save maybe one out of many? Is it statistically significant? This is what the studies say. The meta-analysis, it's not. On the other hand, one could argue and say this very one patient that survived had the surgeon and survived, but although not statistically significant, it's an ethical question, I think. And but if we take the fact into consideration that now a valve, Ziegel valve for Michalis with 8 French profile is being tested, then maybe the future and the nature of the development will answer these questions for us in terms of the of less necessity of having a surgeon or a surgical department on site, but the future will show.
Okay, thank you, Aki.
Anyway,
any last comment before we go to the
No, I
Friday's
think
vignette?
that it would be nice to have a longer sort of this type of conversation and be more active and engaged into this one. People usually are not very sort of used to this engagement, but the president of the Congress wants to push on, and he's very late, and he wants to carry on with the next
as always,
session.
yeah, as always, we left.
And I will ask Dr. Maginas to come to the podium.
Yes.